Hello everyone, how are you? This is Ashir Ahmed from Kyushu University, Japan. I wish I could go to Indonesia and meet you in person, but unfortunately I couldn't make it this time. So I'm I'm sharing my presentation slides through video. So the title of my presentation today is Designing an Electronic Personal Health Book for Elderly. Recently, I have been working on portable health clinic that was designed for the unreached community, people living in rural areas, or people with disability, elderly people who are very difficult to reach. So I was planning how to deliver the services to those people. Today, I would focus on personal health book for the elderly. So if you look at the characteristics of the elderly, there are some common conditions. For an example, hearing loss, cataracts, refractive errors, back and pain, neck pain, COPD, diabetes, depression, dementia. These are common in any countries for elderly people. They need regular health monitoring. They have lots of health history compared to young people because they have to visit doctors, clinics more frequently than a young person. And they forget to take medicine in time, and they really want to talk to somebody to share their health issues. Sometimes it happens they cannot express their health issues properly to the medical experts. So medical experts, if without any information, it is difficult to make a clinical decision. And many elderly people who cannot go to hospitals, they want the services to be delivered at home. And the big challenges is the elderly in rural areas, for an example, where there is no doctors sometimes, there is no clinics, even there is no healthcare services. So today my talk will cover 4 keywords. I will talk about elderly at unreached communities. How can you identify the local resources if you do not have like medical facilities in that area? How can we identify, or we can train, empower the local resources to provide the services? How we can use the artificial intelligence if you don't have facilities or if you don't have the right resources. And then I will talk about social business model as well to deliver the services. So if we talk about low resource settings, unreached community, it happens like it's unfair distribution of healthcare facilities or healthcare resources in urban and rural areas. In urban areas, the facilities are better. The rural areas, there is either it lacks the facilities or they do not have the facilities. There are lack of doctors in developing countries, and also there is a trend that doctors do not want to stay in rural areas. So that's the problem, and we cannot really blame the doctor because they have their livelihood requirements. So that's why we cannot really welcome the doctors in rural areas. And quality hospitals do not sustain without a stable income. In rural areas, a lot of poor people as well, unaffordable people as well, and in developing countries we do not have health insurance, so we cannot really cover their cost. So that's why the hospitals cannot really sustain in the rural areas. And sometimes in some countries in Africa where population density is small and the healthcare facilities are far away from their place, so in that case the transportation cost become bigger than the treatment cost. It happens in Bangladesh as well. For an example, if the local facilities the healthcare facilities are far away, then they have to cover the transportation cost, and the treatment cost sometimes it's free because government hospitals sometimes are free. Not all of them, but a few of them. So I will focus on digital health. There are a lot of advantages of digital health. That's one of my topic that I will talk about today. The the clinic that we developed is called Doctor in a Box, and the all the clinics or all the facilities of medical facilities can be allocated into a box, and that box can really serve. Now let me explain the basic concept of doctor in a box. So let's compare with the traditional or typical clinic in any countries in the world. So there are three components, as you see the left side of the picture. There is a nurse, diagnostic tool, set of diagnostic, and a doctor. So with these three components, you can really build one clinic in any areas. So but if we do not have nurse in the rural areas, if we do not have the diagnostic tools, and if you do not have the doctor in the rural area, that's why the clinics cannot be set up. So the idea is, the out of the box idea is, if you do not have a nurse, we can build a healthcare worker. It's called paramedics in Bangladesh. And if we can provide them some technology, they can act like a nurse. And for the diagnostic tools, we do not need those big machines. Of course, the big machines are good. They can provide you quality services. But at the same time, if we can think of the new technologies that are coming, very small type of sensors are designed and which can be used and can put into a box. So all these sensors, even these days, these are becoming very accurate, small, and also cheap and affordable. So this can be really allocated into one box. But what can we do with the doctor? We cannot really put the doctor inside the box. So the idea is, can we put the doctor and connect to the doctor by using telemedicine system? So it's nothing new. Everybody used this kind of telemedicine system for a long time. So but within the system, we are calling it a portable health clinic as well. So the lady can be work as a nurse. So the box can be carried by the healthcare worker, and when she visits the patient, and the doctor can be connected with her, so that all the services that a clinic can provide can be delivered to a patient. And the advantage is the service can be delivered at home. So instead of a patient visiting a clinic, but the clinic can visit the patients. That's the idea. So now I'm going to show you a video, the way that it is really working in Bangladesh. The concept is, as I have mentioned, there are four components. One of the component is this health clinic box, where all the small sensors can be accommodated inside the box. So the box is carried by one healthcare lady. She is the lady. So she is taking the measurements, starting from all this vital statistics, vital information, height, weight, BMI, and blood, urine. All those kind of experiment can be done, and all not test, not experiment. This can be done, and this information can be inserted into a tab. And from the tab, it can triage or classify the patients into 4 colors. So the emergency or the patients that need discussion with the doctor, they can communicate with the doctor by using, and the doctor can write a prescription. The prescription can be locally printed. So this is how all the functions of a clinic can be really designed inside one box. So that is called portable health clinic. So by using this portable health clinic. Inside the portable health clinic, we have the triage. It's artificial intelligence based triage to classify the patients into different colors. So different colors meaning the status of health, from green to red. So in our experiment so far, from 2010 to 2020, it's a long, like 10 years, monitoring in different locations in Bangladesh. We found that 31% patient need only doctor consultancy, and 69% of the patient can be treated by the healthcare worker and the technology itself. So by doing this, we can really save the doctor's time, and doctors are the most important or expensive element inside this in this design. So if we can reduce the cost, that really reduce the burden of the physician, then it can help the physician shortage problem as well. So as I said, there are 4 components. Let me go one by one. As you know, life expectancy is increasing day by day, any country. So if you look at in 1965, life expectancy of many Asian countries was between 35 to 60. But now in 2020, the life expectancy is almost like from 60 to 80. Japan is doing very good in their life expectancy is almost like 87, that one of the top in the world. But also the developing countries, the life expectancy is becoming very high. In Indonesia, maybe it's 73, Bangladesh 73, and the world average is 72. The idea is we really don't want longer life. Of course, we want longer life, but we don't want longer bed life. So and also the population is increasing in Bangladesh. Year 20, we had 10 million, almost like 10 million elderly people, but in 2050 it will be 3 times. So the burden of elderly people in the society will be very big. So I was talking about 4 components. One of the components, important component, is the box itself. So what is exactly is inside the box? We are not really started by a curative solution, but it's more like a preventive solution. So the box, the content of the box has general items like body temperature, BMI, waist to hip ratio, blood grouping, hypertension related measurement like blood pressure, heart rate, arrhythmia, and diabetes related measurement like blood sugar, urinary sugar, kidney disease, and gout related information is like urine protein, uric acid, liver disease related like urinary urobilirubin, and infection related measurements are like body temperature, body oxygen level, and others. Cholesterol, hemoglobin concentration can be measured. And there is an optional items, but cannot really put inside the box, like cardiovascular related ECG machines, maternal and child health related diseases. Those kind of stuff is also are considered inside the box. So how the delivery can be done, we focused on the universal healthcare coverage of United Nations or SDGs, how we can, and that's mentioned in SDGs 3.8, how we can cover the make the healthcare delivery universal one. So we targeted the most difficult people like rural areas or elderly population, and how we can really serve them by using our model. So we have three type of model: a shared model, dispatch model, and micro healthcare entrepreneur model. So micro health entrepreneur model will serve the individuals. Dispatch model can serve a group, like in the academia or industry, where primary health checkup should be done. In Japan, they have this annual health checkup for it's compulsory for all the students and also all the employees as well. And shared model can be done by using sharing the resources. Some institutions who already have healthcare facilities, like schools and some industry, they already have healthcare services, but it doesn't mean that they have advanced, meaning like they don't keep the health record in a digital manner. So we can work with them by using their facilities and using our software system so that we can work it out. So that's the delivery model. As I mentioned, that healthcare worker can be like if you have a lot of unemployed girls in the rural areas, how can you identify and empower this unemployed girl and turn them into a micro entrepreneur? So in Bangladesh, they can take a paramedic certificate within 6 to 12 months, and they know the basic how to treat patients for NCD related diseases. So they become a health worker, a certified health worker. Then we can give a training for 2 weeks so that they the training will about how to operate the box, and also some entrepreneur training. We don't want her to be a salaried person, but she can be an individual entrepreneur to serve the community. So there is a model in Grameen. It's called a social business fund. So the social business fund can fund this lady, so she can use this portable health clinic to serve the community, and the investment can be returned, but without any interest or anything. The social business model works like that way, and they don't have to provide any dividend as well, so that she can make her business, and it will be monitored by the social business experts. So now let me talk about the data that we collect through this providing the services. There are 4 type of data that becomes in our database: registration data, health checkup data, conversation data, prescription data. All these 4 kind of data comes into PHC database. So if you look at the database from 2010 to today, we found that we have 44,460 records, and there are 34 different items inside the PHC data. Some data was collected in the beginning, and some data was some measurements were added later. So we have different type of data. And if you look at the data, when we started data analysis, we found a lot of missing values. There are a lot of outliers as well. There are a lot of errors as well. And we tried to check like what kind of data are missing and what kind of data brings errors, and why those kind of errors are occurred in when the healthcare worker inserts the data. So since the data is not automatically inserted, they manually insert. So we found a lot of erroneous data inside the database. So if you can have a look at this pair plot, it looks like there are a lot of ugly data as well. It doesn't show any pattern. So we try to process the data by cleaning the irrelevant data, and also identifying some outliers, and trying to understand not all outliers are errors. So identify some inliers and outliers and find out the errors and cleaning those errors. Then we used like 36,462 records times 26 by removing the unnecessary or privacy related data. So after cleaning the data, now we can see there is a pattern now, and after looking at the pattern we found that almost 90% missing data was there. So it was either not measured or not recorded. So deleting the records with missing data will reduce the sample size. It's not good for machine learning. So we want to use this data for some sort of machine learning, and if the data size is reduced, then it is very difficult and we cannot really see the pattern. So we want to predict the missing data. Normally prediction happens for future, but we want to predict the past, like the data that has not been measured or the data that was looked at errors. So can we predict the data and insert the data by using our prediction? So we found that we did a lot of trials and find out what technology is good. There are many machine learning algorithms. We found out what combination will give you a better solution. So we found that the prediction accuracy is almost like 97%, which is the highest in this category. We tried to predict diabetes, and we found that if diabetes can be predicted, we can reduce 94% of the cost. Also, we tried to see the pattern between Bangladesh and Japan, so that whether or not the prediction model in Bangladesh can work in Japan. But of course, the regional characteristics are different, so it may not fit directly, but we want to try it in Japan as well. Also, we tried the prediction of blood uric acid, and we found that we can predict blood uric acid with a very minimum error rate, which is less than 0.03. We came up with a model for the busy doctors. Doctors want to know the previous history of a patient, but previous history for an elderly person is very, very long, so they have many health records. The doctors want to see all the health records in a single shot. So we designed, we call it a Gantt chart. So all of your whole life history can be put into one window, and then the doctor can check the important life health events and can understand better your health history. So as I said, that elderly people cannot express their health issues or their past history easily to the doctor. So in that case, the doctor can see this Gantt chart and find your health history. For the when we use a lot of AI and check the health status, or we predict the health status, but we never know what is happening inside the prediction model. So we wanted to see a deeper insight the model, how it happens, why it happens, what like if somebody is detected unhealthy, but why the person was unhealthy, what parameter really was influential to become an unhealthy person. So that can be explained by using XAI technique. So the doctor also has, and the doctor side, there are problems. Doctors do not want to, the elderly doctors do not want to use ICT or don't want to use computers. They use handwriting handwriting prescriptions a lot of time. But as you know that doctors' handwriting they write very fast. They have to, in developing countries, they have to check many patients in a small amount of time. So they write very fast. And when they write very fast, their handwriting becomes very, not very easy to understand. So pharmacists always complain that they don't understand the doctor's prescription. So what it happens is, like, sometimes the pharmacist give the wrong medicine, which is not really expected. So we developed a system, a pen for the doctor, so the doctor can really write by using that artificial intelligent pen, and the pen nib is a sensor, and whatever the doctor writes, it can be converted into text. And also by analyzing the conversation between the patient and the doctor, we can easily predict a prescription. So that's one of the goals, that can we predict a prescription. But keep it in mind that predicting prescription may be a good idea, but it's not a good idea to use it directly. So what we do is predict the prescription, but we show it to the doctor for the final confirmation. So without the doctor, prescription will not given to the patient. So in this process, after giving the prescription, is it the whole history? No. After that, we want to see whether the elderly person really the medicine was purchased or they take the medicine. How can we monitor that activity? One idea is we can have our member organizations like the pharmaceutical or the medicine shops where medicines are sold. So wherever they go, if they use their ID, inside our system, we can understand how many medicines are purchased by using that prescription. And it can be paperless as well. And the medicine shop can enter the system and check like what has been prescribed when the patient wants to purchase medicine from the shop. So this way we can solve the problem of like whether the medicine were purchased or not. But whether the elderly person take the medicine or not, it is very difficult to trace or difficult to understand. We took a survey in a village to look at how many people are really purchasing the medicines. We found that 75% of the population they purchased all of them, 23% purchased partially, and 2% didn't purchase. So there's a very good acceptance of this technology that people are using e-health. So it means that they're using their pocket money to purchase the medicine. It means that they're really trusting the system or trusting the doctor. So medication monitoring system, we found 3 components to do that. One part is like if all the data is archived digitally, then we can see the e-prescription. Inside the prescription, we can understand the medicine schedule. As you know, that when the doctor prescribe one medicine, they write after the medicine name. For example, you take 1 dose in the morning, 0 dose in the afternoon, and 1 dose in the evening. So that kind of information can make a schedule for the patient. Then schedule like a calendar, and as you know, our calendar can give you some alerts. So the alert can be done into 3 different ways: voice, text, or email. And also it can be sent to the family members as well, so that family members also know. And the alert can be done to provide the medicine to the patients. And as I mentioned, that we have a goal to gather the health records in a personal health book, so that the doctor can check and visualize the patient past history in one way. So how can we do it? All the information that are collected, if it is within one hospital, it is easy to manage, but if it is in different hospital, then we have to collect that information. Recently, there are many initiatives for standardization process to collect this information, and interoperability issues are also discussed. So we can gather them ideally in a database. Then the data can be shared within different hospitals and pharmacists as well. So we took a small experiment to check whether it will work or not. We found that the healthcare worker can serve 20 patients per day, and one doctor call duration was like 3 to 15 minutes, and they can treat 16 maximum patients per day. So we tried to see whether the performance without the PHP and performance with PHP. So the time is reduced, so it means that the performance can be even better. This is a system that we developed for person with disability. As you know, some people who do not have legs or do not have arms, how can you take their blood pressure, for an example? Of course, there are some technologies, but when we try to do it, then we found all these requirements. People who cannot hear, how can they communicate with a doctor, remote doctor? People who cannot see, how can they really read the prescriptions? So we develop one system like people who cannot hear, can we convert the sign language to text, and the doctor on the other side who doesn't understand sign language, they can just read the text. So an easy process that the sign language can be converted into text. That's the challenge, and it can be done. So far I discussed that how elderly people can be treated. We use different type of technologies. One kind of box is portable health clinic that can serve people in the rural areas and elderly population, whether healthcare worker can go support them. And we discussed the disabled people. We checked like how some prediction can be done to reduce the cost and burden of the physicians. But it may look like very good, but there are a lot of challenges when we implemented it into different places in Bangladesh, Malaysia. We did it in Thailand. We partially did it in India. In Cambodia, 7 countries we tried this same thing. And also we are willing to do it in Indonesia as well, if we can find the right partner or right organization to do it together. The 3 types of challenges are there: social challenges, technical challenges, and big business challenges. The social challenges are people don't want to see a virtual doctor. They want to see a real doctor. They want to talk to a real doctor. So how can we really solve the problem? Of course, 75% of the people who bought all the medicine, it means they trusted them. But we have to make it clear that everybody really trusts them and receive the services without any problem. So the technical challenges in rural areas, the internet facility, the power facility is not good enough. So how can we deal with that? And also, as I mentioned, there are a lot of errors. There are a lot of uninserted data. How can we deal with them? And also the not doctor friendly solutions are there, but technology can be improved to solve them. And the business challenge is how can we really make it viable? If government can fund this is very good. Then can be like part of Indonesia's plan is to empower the local community health clinics. So and in Thailand, like they are providing some sort of health insurance so that the plan can be done. So somebody should pay, and how if the patient cannot pay, either the government will pay or some third-party organization can pay. But that business model can be designed so that we can serve the patients easily. One thing that I really want to mention that we should not replace a doctor. Whatever technology we develop by artificial intelligence, we can assist the doctor, but we cannot really replace the doctor. And for the social business, we want to put more fund on the bottom of the pyramid, like people with low income. That's why Grameen in Bangladesh is trying to develop more micro health entrepreneur in the bottom of the pyramid, so that the technology and youth people will be the power and they can solve problems. So this is the summary. I discuss the problems: impossible to run hospitals in remote areas, rural areas, and serve the elderly people. And it is not very easy to increase the number of doctors. We lack doctors in rural areas, but now we can, by using the technology, we can really connect the doctor who are living in urban areas, and we can connect them at their available time. And the research challenges are the usability of the devices, and as you know that the technology is changing every day, so we have to change our devices as well. So and the training should be continued and it is not very easy because we have to change the redesign the box if some sort of new devices are coming in, and the software system needs to be updated as well, and the training needs to be continued to provide the delivery services to the healthcare workers. So challenges are there, but it's fun working with like the local people who didn't see some doctors in their whole life. So it brings a lot of social impacts. That's the really encourages part for our researchers as well. And I discussed the portable health clinic usability only in rural areas in developing countries, but it can be used as a reverse innovation to developed countries as well, like Japan, when there is they are actually losing population, and the rural areas is also becoming doctorless. And also sometimes when there are some natural calamities happen, it doesn't mean only in Japan, anywhere in the world. After that, at some point, all the existing infrastructures are destroyed. So at the time, the portable health clinic can work in both developing and developed countries. And there is a big issue, policy and privacy issue. There are some activities. GDPR in Europe is being practiced, and also it is well defined, but it's not widely deployed yet. And also depending on the country, the policy and privacy issues are different, but we have to cover it up. So thank you very much. I look forward to your questions, and if you have any questions to me, you can write an email. I will send offline. Thank you very much.